Good evening, everyone, and a warm welcome once again on a Wednesday night to IDEC Wednesday Cafe. You know that we bring you from IDEC team different topics of interest in science, in metabolism, diabetes, in obesity, and all about metabolic medicine. We have experts from all over the world. We also have people joining in from more than 35 countries to listen to these webinars, connect with us, and attend our IDEC conference, which is in the second week of July. We will be telling you more about that. Another notice before we start is whatever is being taught today, because it's a lot of information, knowledge, and if you want to replay and relearn, this will be available on the IDEC website after a couple of weeks, and one can review what has learned today. So with me is my team, our founder, Dr. Sanjay Agarwal sir, Shilpa Joshi, who is our nodal leader. She is our nutritionist who leads our nodal wing. And of course, we have Dr. Nitin Kapoor. So he is our today's very esteemed speaker, but we have the pleasure of having him as a partner in IDEC team. So it's a pleasure today, Dr. Nitin, to introduce you, and he will be taking us today into a topic which is definitely his field of expertise. It's something that we all want to learn. We know very little about. We want to implement in our day-to-day practice. So Dr. Nitin is a MD Medicine, DM Endo, postdoc fellowship in endocrinology, ABPDM from USA, a PhD from University of Melbourne. He is currently the professor and head of Unit 1, Department of Endocrinology, Diabetes and Metabolism at CMC Vellore. He has been cited amongst the top 2% of most influential researchers across the world by Stanford University, USA, in October 2023. And wow, and we have the pleasure of having him here with us today. He has also been conferred with many awards. I'm not going to name them all, but a few are ARSAID Gold Medal for Endocrine Society in 2020. And he has amazing number of publications, more than 300 PubMed indexed peer-reviewed publications. So he's genuinely an expert in the field of obesity and metabolic syndrome, pituitary disorders, and metabolic bone disease. It is a pleasure to have you, Dr. Nitin, here. And today will be a master class. So he is going to take an entire hour of showing that he's a professor and teaches all the aspects of Dexa scan and how it can be used. Over to you, Dr. Nitin.
Thank you so much, Dr. Archana, and everyone for having me here. It's indeed a great pleasure to join IDEC Cafe on behalf of Team IDEC, belonging to the team here myself. And a very warm welcome to all our delegates who've joined today for this particular session, which is on DEXA scan interpretation. So I think, friends, this is a big topic, and it would be almost an hour that I would be covering. But I have tried to make this topic as clinically relevant as possible. And during the course, what I would do is actually present cases after a brief introduction and some basics that we need to know. We are going to listen to real life cases that we've seen, maybe about 15 different cases across different domains of the DEXA reports that we can get. So that's what we are going to do, and we'd be happy to take any questions towards the end. Please feel free to post your questions in the question box that you see on the screen. So friends, talking about DEXA, I think all of us during our training know that DEXA scan is something which is known to be the gold standard for assessing bone mineral density for people with osteoporosis. So this is what most of us would definitely know, would have heard that, yes, DEXA scan is used for finding out whether somebody has got a weak bone or not. But is that all that DEXA tells us, or is there something more? Frankly speaking, there are a lot more things that DEXA scan can do, and I've just put a few of them on the screen here. Yes, we know about the bone mineral density part of it, but it also tells us about another aspect, which is the VFA, or the vertebral fracture assessment. So yes, we can know whether somebody has a fracture or not with an X-ray, but on a DEXA scan, we would know what is the type of fracture, what are the measurements, the number of fractures, the kind of severity of fracture that a patient has. So a lot of information can be assessed with respect to that. What we also can learn from a DEXA report is something called a trabecular bone score, which is something to do with bone microarchitecture. Mind you, this is something that is considered as the gold standard for assessment of bone health in patients with diabetes. IDEC being a predominant association talking about diabetes and metabolism. We'll see how a DEXA scan can be very, very relevant in all these metabolic disorders. And I repeat that bone microarchitecture by TBS is today, by all international guidelines, recommended for assessment of bone health in people with diabetes. And we'll learn more about it as we go ahead. Yes, it can also tell us about atypical femoral fractures, tells us about hip geometry. Again, we'll learn about it. And last but not the least, it also tells us about body composition analysis. And again, I think we all are seeing an epidemic or a pandemic of obesity. But along with that, an upcoming topic of interest is also sarcopenia and sarcopenic obesity. And we'll see how body composition analysis also helps us to understand that. So friends, the point that I'm driving here is that DEXA is just not BMD, it's a lot more. And we'll see how we can really learn about these different aspects. But why do we really need an hour? And why on IDEC platform do we need an hour to discuss DEXA? Let's see that in a brief introduction as we go ahead. And what we know today, or what we have learned, that what is coming in the future is something called as the gray dawn or the gray wave. What does that mean? It means that our life expectancy is definitely increasing. This is data from India, but globally, yes, we know our life expectancy is increasing. Some of the states in the Indian subcontinent today have life expectancy, which is as high as many Western countries. So how does it affect us as healthcare professionals? Well, it does affect us because we are going to see more and more elderly people in our clinical practice in the near future. And for us, we have to be more apt and more ready to handle problems in the elderly as we see these patients. So yes, problems like diabetes and obesity are going to be on the rise, sarcopenia, and also osteoporosis. Mind you, a DEXA scan can really help for all of this, and we will see that in the next couple of slides. So why is this important? Maybe if I just very briefly talk about osteoporosis. Yes, how common is osteoporosis? This is a study from Well, about half of postmenopausal women in India, about 50% of postmenopausal women in India have osteoporosis. So this is something really, really common. Are men spared? The answer is no. About 20% of men, that's about 1/5 of men above the age of 60 have osteoporosis. So here we're talking of a disease which affects 50% of postmenopausal women and 20% of men above the age of 60 years. Well, if somebody has osteoporosis, they are at risk of developing fracture, a fragility fracture, a fracture which is a low trauma fracture. So what? So if somebody develops a low trauma fracture, if you take the example of a hip fracture, well, what we really need to know is that if somebody develops a hip fracture today, the mortality of that patient, irrespective of where the patient is in whichever corner of the world, even in the most developed nation, the mortality which is associated with a hip fracture is about 30%. So if 3 postmenopausal women sustain a hip fracture today, one of them will die within a year. Friends, we're talking of a disease which is common. I said that people with the elderly age are going to be more. So this is going to become more common in the future. And we're talking of a disease which has such a high mortality-related consequence. How does it relate to diabetes? Well, today, diabetes is considered as the #1 cause associated with osteoporosis. So today, diabetes is considered to affect bone health, not only by high HbA1c, by the inflammatory markers and all the complications that we read for diabetes, the microvascular complications, right, from advanced glycosylated end products to the different pathways, all of them have shown to affect bone. And today, the Indian Society of Bone and Mineral Research from India and the American Society of Bone and Mineral Research talk very specifically how both type 1 and type 2 diabetes increases the risk of fracture and increases the risk of morbidity and mortality in patients with diabetes. This is a study that we did here in Vellore, which showed not only these people have more osteoporosis and poor bone strength and bone quality, but also more fractures, as we had checked for this particular study, which was published in Osteoporosis International. So, friends, cutting a long story short, we're talking of more elderly people in our society. We're talking of osteoporosis, which is a common disease, and we're talking of something like diabetes, which we all treat, is associated with osteoporosis. Is obesity related to osteoporosis? Again, conventional teaching has always taught us, okay, more the estrogen, more the fat, better the bone. But that is not true in people who have severe obesity. If you look at this data again from Vellore, where we look at how the bone mineral density increases in people who are non-obese, who become obese, but those who become morbidly obese have so many other problems, right, from obstructive sleep apnea to fatty liver disease. All of these inflammatory conditions have shown to affect the bone density, and definitely they have a higher risk of fracture. They also have poor bone quality. So yes, we're talking of osteoporosis not only being associated with diabetes, but also with morbid obesity. And the third thing that I'd highlight before I move on to the different cases is talking about sarcopenia, which is another attribute of aging, wherein we know that muscle mass tends to decrease as we age, the fat tends to increase as we age. This is another very common problem in the Indian subcontinent when we look at the national prevalence of sarcopenic obesity and sarcopenia. So sarcopenia is about 41% in this particular study, nationwide survey in India in about 70,000 people. So yes, we're talking of all these diseases. They're all interlinked. The muscle, the bone, the fat, and all of them are interlinked. And when we are treating these patients, we cannot say that we are just a diabetes specialist and I'm just going to look at the glucose values. What about these other comorbidities that are often lethal? Am I not going to assess my patient for that? What if my patient comes with a hip fracture? Am I not going to treat? Or I'm going to refer to another physician? Why not I myself make myself well trained enough to understand what the disease process is? The sarcopenic obesity is another big problem. It has significant impact on cardiovascular health. Again, a significant impact on mortality. And as we see that the mortality does increase as patient develops sarcopenia, so much so in this particular graph, I'd really like to highlight that people who got obesity will have less mortality as compared to people who have sarcopenia or sarcopenic obesity. So yes, long story short, I think all of us as physicians need to know the clinical utility of Dexa scans in our clinical practice. And I've divided this topic in 5 brief domains. In the first 2 domains, we'll talk about different factors where we would see abnormalities in the bone mineral density, either a high bone mineral density or disorders with low bone mineral density. The third aspect that I would cover here is predominantly body composition. We'll have an in-depth discussion of how body fat assessment helps us in clinical practice. How do we make sense of muscle mass and body fat distribution? And the last 2 aspects of my talk, I would really cover the more recent or the newer developments in DEXA scan. And as I mentioned before, that trabecular bone score is today considered as the best way of assessing bone health in people with diabetes, because the BMD can be sometimes falsely high in these patients. And also I'll talk about the hip geometry. So these are the 5 different aspects that I'll talk about today in terms of DEXA report. But before we jump into any of these cases, let us first try and see how do we interpret a normal report without any disorders. So when we have a patient in front of us and the patient gives us a DEXA report, in this matter for a bone mineral density, how do we go about looking at the report? And I think if I have to highlight the first most important step that we have to do here is to try and understand what is the age that has been mentioned by my technician on the report. This is a very, very important checkpoint, because if my technician has entered a wrong age on the DEXA report, the calculation of the scores below would be based on the age that has been entered. And if that is wrong, our entire report understanding would go haywire. So it's very, very important to make sure that my patient's age is as close to the age of our patient. I know sometimes in practice, our patients, especially from the villages, would not know their age, but at least we know somebody who's 60 cannot be written as 40. Because if I write somebody who's got an actual age of 60, but if it is mentioned as 40 in the report, then all these reports are going to be looking very bad. Even though the patient may have normal BMD, their comparison would be as if this patient is supposed to be 40 years old. So friends, the first message that I would like to leave here is that yes, it is very important to make sure the age on the report of the DEXA scan that you're seeing is exactly the age of your patient. Irrespective of what is mentioned in the hospital card, what is mentioned in the hospital number, that does not matter. After we have looked at the age, the next step is to try and understand whether this patient has a bad bone or not. And for that, we see that there are several scores which are mentioned there. There's a T score, there's a Z score. So how do we decide which score is the best to look at? Well, looking a little bit into more detail, when we talk of a T score is something that we compare the patient's density to a patient who is supposed to be a young, normal, age matched, gender matched patient. Whereas a Z score is something that I compare patients' BMD to an age, gender, ethnicity matched patient. But that's just the science behind it. I think as a clinician, what I really should know is that if my patient's age is between 50 to 75 years, I have to look at the T score. And if my patient is younger than 50 years or older than 75 years, then I have to look at the Z score. That's the important message that you have to remember. So you look at the age of the patient first, make sure that the age was correct. Based on the age, you decide whether you're going to look at the T score of the patient or the Z score. You're going to look at the T score if the age is between 50 to 75 years, and you're going to look at the Z score if the age is less than 50 or more than 75. Right, so once we've looked at the score, we need to know whether that is normal, abnormal, or something borderline. So if I'm looking at T score, and you can see over here in the on the slide, the different definitions. So anything which is less than minus 2.5 T score is defined as osteoporosis. So if my patient has a T score of minus 3, minus 4, minus 5, I know that patient has osteoporosis. If the T score is between minus 1 to minus 2.5, yes, that would be called as osteopenia. And if the T score is above minus 1, so above minus 1 can be 0.5, can be 1, so that is said to be normal. Just like to add a point here that if it is more than plus 1, then we consider it to be sclerotic bone disease, and we'll see a few examples of that as well. So far, I hope I'm very clear. What I'm mentioning is that we're looking at the age of the patient. Based on the age, we decide whether we look at the T score or the Z score. If the age is between 50 to 75, I look at the T score. If the T score is less than minus 2.5, there's osteoporosis. The T score between minus 1 and minus 2.5 would be osteopenia. Anything above minus 1 up to plus 1 is normal. But what if my patient was less than 50 years or more than 75 years? In that case, I'm going to look at Z score. If I'm looking at the Z score, it's less complicated. There are just two classifications. So if the Z score is less than minus 2, I would say that patient has low bone mass. More recently, this terminology is being changed. It's called BERA, B-E-R-A, called below expected range of for age. So yes, if my patient is between below 50 years and has a Z score of less than equal to minus 2, I would say this patient has low bone mass or BERA. And anything more than that would be said to be normal. So friends, that's how you look at the bone mineral density. Let's go back to the patient that we just saw, and we saw the age of this patient, and I presume that this age is correct. So the patient's age is 53. So which score I have to look at? Yes, because it is between 50 to 75. I have to look at the T score. And once I look at the T score, I see that all the vertebrae are in the range of minus 3.8, minus 4.2, minus 4.3, most of them as minus 4.2. So yes, this patient's T score is below minus 2.5, and hence this patient, who's a 53-year-old lady, has osteoporosis, needs treatment. Right. What about body composition analysis? Let's look at how we interpret body composition analysis. And this is a snapshot of a body composition analysis report on a DEXA scan. I would divide this report in 5 brief domains. So these are the 5 domains that we look at. We look at the demographic details. We talk about the body mass index. We look at the total body fat indices, the muscle mass indices, as well as the regional fat indices. We look at it, all of these 5 domains in more detail. So when I talk about the demographic details, I think just like I mentioned for bone mineral density, where I said that a T-score and a Z-score has to be based on the age, I think the importance of age is equally held up here as well. So again, when you're looking at a body composition report, irrespective of whether that's DEXA or whether that's from InBody or from any other body composition analyzer, all of them compare the body composition of the patient given to an age-matched patient or a normal reference. And if the age is mentioned wrongly, you are definitely going to get the wrong percentiles. So please make sure, even in a body composition report, that the age that has been entered for this particular test is the actual age of the patient. In addition here, I'd also like to mention that in demographic details, when you're looking at body composition, it is indeed very important to also look at the weight of the patient. Now, the weight of the patient here is actually not something that is measured by the machine. What you're looking at, the weight in the demographic details section, is a weight which is actually entered by the technician and is entered based on a weighing scale which is there in the DEXA scan room. You will get a weight from the DEXA machine as well, and I'm going to show you that as we learn more about it. But I must highlight again here that this weight and height that you're seeing in the demographic details section of a DEXA report is something that is entered by the technician and is not by the machine itself. The second aspect in the DEXA report of a body composition, rather the next 3 that I would take together, that is body mass index, the total body fat parameters, and the muscle mass parameters. So we look at these 3, but just before we get into these 3 parameters, we need to learn a little bit more about assessment of body composition. And body composition can be very complex. Some of the basic science studies that we do and can be done. It could be at the atomic level, it could be at the molecular, cellular, and the tissue system level. But all along, scientists have made it really simple for clinicians to understand body composition. And what has always been proposed is a very easy to understand 2-compartment model. What does this 2-compartment model tell us? It tells us that the entire body is just divided into 2 parts. One is fat, and everything else, be it muscle, be it organs, be it whatever else, is the fat-free mass. So because we as physicians are interested in understanding what is the fat mass, all the others would be called as fat-free mass. So yes, this is the 2-compartment model, which is also today followed in most body composition machines, including the DEXA. But more recently, we are understanding the 3-compartment model, where we look at the fat mass and everything else, which is either a lean mass or a bone mineral mass. But for simplicity, let's stick on to the 2-compartment model that we have, which is the fat mass and the fat-free mass. And with that background, let's look at in detail about body composition analysis with respect to the BMI, the total body fat indices, and the muscle mass indices. So these are the 3 domains that we look at. And again, what I'd like to really highlight here is that in the BMI section, you see a BMI of 24.1 for this patient. This is a BMI which is again mentioned by the machine where the technician has entered the value. So this is not something that is calculated by the machine. So again, this BMI is 24.1, is something based on what my technician has entered. Looking at the fat indices and the muscle indices, if I was to again make things simple, we would look at 5 things in total. But the first thing that I would highlight is the fat by height square and the lean by height square. And this is where our knowledge of the 2-compartment model helps us. So friends, as I said, in the 2-compartment model, the whole body is divided as fat mass and the fat-free mass. So if I add the fat mass by height square with the lean mass by height square, I get the BMI. So that's an indirect way for me to assess whether the patient's BMI, which has been calculated based on what my technician has entered, is absolutely the same as what the machine is telling me. So ideally, the fat by height square, when I add to lean by height square, should be equal to BMI. We also see something called as total body fat percentage here, which is 39%. So yes, there are different cutoffs followed globally. This is data from the Endocrine Society of India Clinical Practice Guidelines for Obesity Management, where we've got cutoffs data plus 25 and 30%. The Western cutoffs by the American College of Clinical Endocrinologists is 25 and 35. And a more recent paper, which is currently in press by Dr. Anup Mishra's team, and is slightly lower than 25 and 30, but as long as you know which cutoff you're referring to and where your reference is from, more or less lower fat percentage for men, higher for women, about 20 to 25, most definitions would tell for men, about 30 to 35, most definitions for women. So this is the body fat percentage cutoff that we need to remember. So in our particular patient that we are seeing, our percentage was 39%. So whether male or female, that is definitely high. And that is the total body fat. What I've also underlined here are two more parameters. Let's look at the VAT area.
We will just check shortly with Dr. Nitin. I think there must have been a
I
connection.
think there was some connection
Yes.
problem. Let me just check.
Yes. Just wait. I'm sure he'll be joining us again.
Right. So I think there was a disconnect for a minute, but then let me go back where I left you with. So here we're talking about the different fat indices. And as I said, there is also mention of visceral fat here. So the visceral fat area here is something that tells us about the bad fat, the fat around the organs like liver, kidney, omentum, heart, the ectopic fat. So the visceral fat that you see here is 61. So what is normal? Again, this is another study done from Vellore a couple of years ago, where we looked at the visceral fat area. Even the global definition for VAT area is something which is 100 centimeters square or more is abnormal. In this particular study, we found that the VAT area above 100 would have an odds of 2.2 for having two or more cardiometabolic risk factors. So yes, the Dexa scan or any body composition machine for that matter would also tell you about the visceral adipose tissue, which is again something that we need to know about. And the last point that I'd like to mention here is the last line that is underlined here, which is the appendicular lean by height square. Now, this is something which helps us to understand the muscle mass of a patient. Again, appendicular lean by height square is something which is used to diagnose sarcopenia here. And as you see, there are different cutoffs for the Asian and Caucasian population. In an Asian population, a value of less than 7 in men and less than 5.4 in women is said to have low muscle mass, which is indeed one of the criteria for diagnosing sarcopenia. Well, if you think that's all, no, there is more in a DEXA scan body composition report. We also get something called as regional fat parameters. This is what you get. And this is the place where you actually get the weight, which has been assessed by the DEXA machine. And as you see, the weight here is, 125 kilograms as assessed by the, weighing scale in the machine. But what has been assessed internally by the machine has been given in grams, about 125,000. If I divide by 1,000, it would be the same as 125 kgs. Again, the total body fat percentage that we saw in the previous slide is something that is calculated here. As we know about the two compartment model, we're just looking at fat mass divided by the total mass and get the body fat percentage. And what is also important here is to look at the regional fat parameters, where we look at how the fat is distributed across different areas of the body. And if it is different, suppose I have a patient who's got a hemiplegia or a stroke. So obviously he's not going to be moving one part of the body. So that part of the body would have less muscle and more fat. And that's how I would be able to identify here. But this is clinically, again, very helpful in people who have lipodystrophy, whether it is because of drugs like anti-HIV therapy or even inherited congenital generalized or partial lipodystrophy. We'll talk about a few of those examples, but friends, these are the 5 broad areas that you need to look at when you talk about body composition. Right. So I think with this brief introduction, let us move on to the 5 domains that I had mentioned before in terms of the clinical cases. The first 2 domains will predominantly cover about the bone mineral density, causes of high and low BMD. We'll just talk about cases. I'll be showing you about 15 cases in total about different Dexa reports and how it is clinically useful. We'll dive into the body composition. We'll also talk about the TBS and the HSA. So let's start with the increased BMD reports in a few cases that I have to show. And the story of my first patient is a 41-year-old gentleman. He was referred to me from orthopedic department for evaluation of bony pains, and he had this particular Dexa report, which he had done. Now, as I said, the first thing that we have to look at when we get a Dexa report is look at the age. So this age, which has been mentioned on the Dexa report, is 41, which matches with the clinical age of 41. So yes, I have to look at the Z score in a patient who's got age less than 50. But when I look at the Z score, I would expect anything like -1 to +1 is normal. But here I'm seeing a value of +6, +7, and +6.8. So definitely this is something very, very high. This Dexa scan can be done at 3 sites. That is the lumbar spine, the femoral neck, and the radius. So I just look at the other side. But to my surprise, I do not find this particular high bone mineral density at the other side. So something has gone wrong in the spine, which is giving a very high Z score in the spine. So what could that be? Well, in a 41-year-old gentleman, he's just got low backache. He's not got any other symptoms. But having known that, men can have sometimes osteoblastic disease, which could be a harbinger of an underlying malignancy of an osteoblastic metastasis. As part of my workup, I had also asked for total PSA in this gentleman, and you see the PSA is skyrocketing high. So yes, this was the index presentation of my patient with a prostate cancer who presented with low backache because the cancer had already metastasized behind to this lumbar spine. So yes, sometimes if you get a very high DEXA report, and this is what you need to remember, the third column here, if you have somebody who's got a very high BMD, are suspecting a malignancy, there are 5 cancers that you need to remember that have predominantly an osteoblastic met. So which are those 5 cancers? It is the small cell carcinoma of the lung, the prostate cancer, as we saw, also neuroendocrine tumors, be it carcinoids or gastrinomas, CA stomach, and lymphoma. So these are the 5 broad tumors that can present with an osteoblastic metastasis. In this case, this Dexa report actually helped us prove the diagnosis. Let's move on to another patient. And this is the story of an 89-year-old lady. She's not had any previous fractures, but is presented again with low backache. An 89-year-old lady, so I would definitely expect her to have osteoporosis. As I mentioned to you, that at the age of 50 itself, 50% of postmenopausal women have osteoporosis. So 89, I'm almost sure to expect osteoporosis. But again, to my surprise, I do not get the kind of osteoporosis that I had expected. So she's 89, so I have to look at the T-score. And when I look at the T-score, I am looking at values which are around 2.5. And if there's a value of 2.5 here, that is definitely abnormal. So when there is a value of 2.5, that is telling us that there is again sclerotic bone disease there. And therefore, when we evaluate further this particular patient, we see that has a problem with the aorta where there is sclerosis. And so if I do a lateral X-ray of this patient, we see that there is calcification of the aorta. This is not something which is uncommon at that age, which is giving a false positive DEXA report. And if I do a lateral DEXA for this patient, you see how the plus 2.5 has become minus 4.3 there. And therefore, yes, again, I have to be careful when I'm interpreting this particular report in these patients. So yes, aortic calcification could spuriously increase the bone mineral density in a patient with osteoporosis when we are expecting the BMD to be low. And to just remember the entire list when in clinical practice, you get a higher BMD than what you expect. So yes, it could be just spinal degeneration or osteophytes. Presence of a fracture, a vertebral fracture, which can be absolutely asymptomatic, can have a lot of callus developed around it and could give a false positive report. Aortic calcification, presence of metal clips, buttons, even a CT contrast. So if my patient has had a CT contrast in the last week, that itself can give a falsely high BMD. Sclerotic metastasis can cause, again, as we saw in the first case, ankylosing spondylitis and also certain medications that include strontium. You don't use that very often these days, but yes, that could also lead on to something causing a falsely high BMD. So with this, let's move on to our third case, and that is the story of two siblings presented with bony pains, chalky white teeth, and very, very sclerotic bone. So again, a young person. So I'm looking at the Z score, but a value of 12.4 is definitely obnoxiously high. And with the history of chalky teeth, I know this is something to do with fluorosis. It's not so uncommon still. Definitely one of the rare sclerotic bone disease, but we still get to see, especially in the south, where there are areas of high, fluoride content. As you can see, the urine fluoride level in this patient was high. We've recently published our entire series of patients with skeletal fluorosis, which is another cause of sclerotic bone disease. So I think, in summary, I show on the slide all the causes of high bone mineral density. But for all the clinicians who've joined here, I think if I was to pick up the top 5 sclerotic bone disorders that you're going to commonly see in your clinical practice, include chronic kidney disease. So all those who manage people with diabetes can develop diabetic nephropathy and CKD. And that is one important common cause of high BMD. So yes, CKD is one. Metastasis, as I mentioned, the 5 particular malignancies that can have sclerotic mets. Prostatic malignancies in men, something which is common, but in addition, CA stomach, small cell carcinoma of the lung, neuroendocrine tumors, and lymphomas can present with sclerotic mets. Third important cause would again be something like renal tubular dysfunction, so RTA, renal tubular acidosis. Multiple myeloma can also have a sclerotic lytic presentation. And then come the other rare diseases like Paget's disease of the bone and fluorosis that we saw. Apart from that, many other cases would be very rare. You need to refer to the specialist for handling them. Moving further with the fourth case, and this is the story of a 70-year-old lady who's done a routine scan. As I said, that above the age of 50, you are expected to do DEXA scan. So what the Indian Society of Bone and Mineral Research tells us that above 10 years of menopausal age, everybody should have a DEXA scan, screening for osteoporosis. So yes, when we're looking at this particular scan, I see that yes, the L4 vertebra is telling me it's minus 2.3. But again, I see an odd value of 6.4 in the L2 vertebra. So what this could be? So again, this could be a sclerotic match, and one of the cancers in women which can present with both sclerotic and lytic lesions is a breast CA. And again, this patient was diagnosed like that. In patients who've had breast carcinoma, need bone assessment because, as you can see in the study, no matter what therapy they've had, whether they've had gonadectomy, whether they've had chemotherapy, tamoxifen, or just observation, whatever be the treatment, in whichever order they've had, one worse than the other, they do have osteoporosis. So very, very important to screen for that in these patients who've had breast cancer. So with this, let's move on to the next set of cases, which is of decreased BMD. And decreased BMD, yes, we've learned about osteoporosis, how we diagnose, but not all low BMDs are osteoporosis. Let's look at this case of the 54-year-old postmenopausal lady presented with multiple bony pains, height loss, and non-inflammatory arthralgias. Well, given that she's 54 and she's postmenopausal, we did a Dexa scan. Now, I wouldn't have expected a T-score of -5 for a 54-year-old lady, but what is the important message that I really want to drive from this particular case is that we have to make sure that we always, do the DEXA scan with biochemistry. In this particular patient, we've done the calcium and phosphorus level. The phosphorus level is terribly low, and the alkaline phosphatase is high. So this is a patient who's got osteomalacia because of a tumor-induced osteomalacia. She had a small tumor which is causing this hypophosphatemic osteomalacia, and just removing that tumor itself has normalized the BMD. So yes, not all low BMDs could be osteoporosis. You have to look at calcium, phosphorus, albumin, and alkaline phosphatase. If there's an abnormality in the calcium, phosphorus, and alphos, you have to first find out that cause rather than jump and treat it like osteoporosis. This is another story of a 44-year-old gentleman who presented with erectile dysfunction for 2 years. So yes, this is again something to do with hypogonadism. They've had an MRI done elsewhere for low backache showing wedging anteriorly. So yes, there is some amount of osteoporosis. You look at the score. So he's 44-year-old. So I have to look at the Z score. The Z score, if it is less than -2, is low bone mass. As you see, the most of the values are between -2.4 and -3.3. So yes, this patient has a low bone mass. But in a male patient, when you get low bone mass, you have to rule out secondary causes. You have to rule out hypogonadism. This patient had a low testosterone, high prolactin, a prolactin secreting tumor, and therefore that treating that itself would improve the bone. So yes, in younger patients, when you get a low bone mass, you should look for a secondary cause of osteoporosis. In men, if I have to highlight the top 2 most common secondary causes of osteoporosis, it would be alcohol intake and it would be hypogonadism. There's another patient who presented with Klinefelter syndrome, again, something which is not very uncommon, having low bone mass. Another patient with Kallmann syndrome, having osteoporosis. And the best part about treating secondary osteoporosis is that when you just replace the gonadal steroids in these patients, that itself would improve the bone mineral density, and therefore it would not require any anti-osteoporotic agent. Moving on to another case, this is a story of a 70-year-old lady who presented with a DEXA scan screening for osteoporosis, and she's got abdominal pain, she's got renal calculi, she's got muscle weakness. Again, looking at the biochemistry here, we see that she's got a high calcium, she's got a high parathyroid hormone. So this is a case of primary hyperparathyroidism. On this scintigraphy, you see that high uptake in the parathyroid gland. And you look at the baseline BMD, which is -2.4. And as we operated within 6 months, there's remarkable improvement in 1 year. We have a near normal BMD in this patient. So again, the important message here is that we should not forget ruling out secondary osteoporosis in individuals who may have young onset or a sudden onset osteoporosis. And this is the comprehensive list that I would leave you with for secondary osteoporosis and hypogonadism. In women, I would say the most common cause is steroid intake. And the steroid intake, as we know, is rampant in India. I mean, I always love to show this particular slide where I show these two sachets of one of my patients who's from northeast part of the country, and she had florid Cushing syndrome. And she would say, Doctor, I've never taken any steroids, no medicine, no injection. It's only during ward rounds I find this to her bedside, and she says, Doctor, this is a very, very effective medicine for joint pain. You can give it to your patients as well. And when I analyze this, it is dexamethasone. So yes, steroid use is rampant in India. Not only does it cause blood pressure and diabetes, obesity, but it also causes osteoporosis. And yes, this is the most common cause of secondary osteoporosis in women that I would call for. There's another sad story of two siblings who presented to us with Cushing's, which was again without the mother knowing. She was giving her two children a powder which somebody had given to her for increasing weight, and she was not realizing that she's putting in milk dexamethasone powder just as a health supplement. And these two children presented with osteoporosis and diabetes at the age of 19 and 17. And so steroid use is rampant in India. So if you have a patient who's got young onset osteoporosis, should think of that as well. So friends, with this, let's move on to the third aspect of the talk, which is on body composition. Let's look at a case, and this is a story of a 36-year-old lady who was presented to the OPD for evaluation of PCOS, polycystic ovary syndrome, but she's got a lean phenotype. She's got diabetes, and somebody has told her because she's got diabetes and PCOS, she has to be on a strict diet, strict exercise. She's a well-educated patient. She comes and asks me, Doctor, my BMI is absolutely normal. My BMI is 22.3 kilograms per meter square. Why the hell should I be on diet? Why should I stop eating, this particular fat? And you're asking me to reduce carbohydrates. That doesn't make sense to me. Yes, she is diabetic, so she needs to have a diabetic diet, but why does she need to lose weight? Well, just one glance at her BMI, what she's saying is correct, that she's got a BMI of 22.3. But that's where body composition would help us. And look at the body fat percentage. We discussed in the earlier part of the session, a normal body fat in women would be anywhere above 30% as per the ASI, or as per the Western guidelines would be 35. This patient has a body fat percentage of 41%. So she's got that classic lean PCOS or a normal weight obesity. The BMI is normal, but the body fat is high. And one show of this particular report to the patient would make her understand why, despite having a normal BMI for her PCOS, she will still benefit by losing weight. So this is what is normal weight obesity, where we talk a patient to have a BMI in the non-obese range, so it should be less than 25, with a higher body fat percentage. Something similar to what Dr. Yagnik had published many years ago in Lancet. And this is a phenotype which is not uncommon in our society. This is a study we did in Kerala a couple of years ago, where we found that about 1/3 of the entire study population and about 2/3 of those people who had so-called normal BMI had high body fat. And again, in clinical practice, we do see a lot of patients with lean PCOS. And this is another study that we did in lean PCOS. And just one glance at the body composition parameters clearly tells us that these patients, despite having a BMI within the so-called normal range, tend to have very high body fat, very high visceral adipose tissue, and therefore these patients do benefit with lifestyle intervention, even despite the fact they have a normal BMI. So that's another use clinically where you can use a body composition for trying to explain to a patient who's got a lean phenotype but high body fat, and would explain why she has PCOS. Does it work in people with morbid obesity as well? And these are two patients who coincidentally presented to me on the same day of the clinic, in the obesity clinic. The first patient was a 37-year-old lady. She's got a BMI of 41. So she came to the bariatric clinic. She's got pre-diabetes. She's not on any medications. So blood pressure is normal. She's got borderline cholesterol, no fatty liver. Coincidentally, on the same day, I had another patient who's got 36-year-old lady, again, BMI of 43. So again, morbid obesity. But this patient seems to have all the metabolic problems. She's got diabetes, A1C is 9%. She's already on two antihypertensives. She's got dyslipidemia, fatty liver. And so you see two patients who are almost of the same age, almost of the same BMI, but one patient seems to have all the florid metabolic problems, whereas the other patient does not seem to have metabolic problems. Both were from a very similar background in terms of their lifestyle, their culture, dietary intake, and physical activity. So let's look at the body composition analysis here, and we see that yes, the total body fat percentage is high in both, rather more high in the patient who has less complications, but that's where the visceral adipose tissue really plays a role. And as I mentioned before, that visceral adipose tissue more than 100 is said to be bad. That is the VAT area, which is the last parameter that you see on the slide. So just 62 for the patient who does not have complications, whereas 133 for the patient who has complications, despite both of them having a similar BMI and a similar total body fat. So that's where the visceral adipose tissue also really helps us decide who needs a bariatric surgery earlier, who needs, who's likely to develop more metabolic problems than the other patient. Moving on to my next patient with body composition, and this is a story of a 24-year-old lady. Again, she's got diabetes, she's got significant acanthosis nigricans and an acromegaloid appearance. This is a clear umbilical hernia that you see, or a button sign. And one glance at the body composition report that we see here is that, despite having diabetes and all the problems, you look at the fat percentage here. So she does not seem to have any peripheral fat in her body. What we see here are two acronyms, the YN, which means if I compare her fat to a young normal person, or AM, which is if I compare her fat to an age-matched person. But whatever all said and done, despite having diabetes and at young age and severe acanthosis, she doesn't seem to have any problem related to fat, or the fat is absolutely not there. This is a classical case of a complete lipodystrophy, which you proved genetically later and published it. But the point that I'm driving here is that, yes, the body composition analysis, the regional fat distribution can also help us understand the body fat distribution in patients, whether, as I mentioned before, if a patient has had a stroke, I would see much more fat on the side which has had the stroke. If I have partial lipodystrophy, complete lipodystrophy, it explains why this particular patient's got diabetes at a very young age. So body composition could be used in several ways in lean patients, in very severely obese patients, and other patients who've got unexplained young onset diabetes as well. So with this, we move on to the last two aspects of the talk, which is on the trabecular bone score and hip structure analysis. And as we know, and I mentioned before, that in patients with diabetes today, trabecular bone score is recommended by all international guidelines as the best way to assess the bone health. So this is a story of a 59-year-old postmenopausal lady who's got menopause for more than 10 years. She's got diabetes for the past 9 years, and she's referred after management of a left hip fracture by orthopedic department. Again, looking at the T-scores, given that she is 50 plus, the T-scores aren't that bad, but that is something which is known in people with diabetes. Sometimes the T-scores may not reflect what the actual bone health is. And that therefore, when you look at the guidelines internationally, both by the American Society of Bone and Mineral Research and the International Society of Clinical Densitometry, when they talk of patients with diabetes, they say that ideally you should be looking at the trabecular bone score. So now what is this trabecular bone score? This is a kind of a score that tells us about bone microarchitecture, irrespective of what the bone density is. In this particular patient, it was 1.15. So this is what is normal trabecular bone score. Is anything above 1.35. Anything less than 1.2 would be a degraded bone. So if you get to see a report of TBS, this is the thing that you need to remember. As I said, in people with diabetes, you should be asking for this because this is what is more accurate assessment of their bone health. Even in the study that we did here in Vellore, it was very clear that patients with diabetes had much worse TBS, much higher number of fractures. The bone density was not really telling us the truth, but the TBS was telling. And even in people with severe obesity, we know that trabecular bone score can be helpful in people with obesity. The short message here is that yes, trabecular bone score is an indirect marker of bone, kind of quality that we can get. And it is important to measure in people with diabetes. A value which is less than 1.2 is said to be a degraded bone. With this, I move on to the last part of my talk, which is on hip structure analysis. So what I really want to mention here is that when you talk of bone health and the propensity of somebody to develop fracture, it's not only the bone density or the bone strength which is important, it is also the hip geometry that plays a very important role. The hip geometry is assessed at different areas, but again, trying to make things simple, we get a very complicated report. But what I really would like you to take away from this particular talk is something called as buckling ratio that we get in the hip structure analysis. A very simple analogy I would give you is, suppose I have somebody who's got a bone like a metal. So metal, we know, is a very solid substance. So if I'm looking at the bone density of a metal, it will be very, very, thick and, kind of an unbreakable thing. But if I use the same metal to kind of make a Coca-Cola can, so the Coca-Cola can would be very thin. Even though it is metal, it is much more stronger as compared to glass or cloth or paper. But a Coke can be very easily crushed. And that is something which is known as the buckling ratio. How easy is it for you to crush a particular bone with respect to the hip geometry? Is calculated based on the thickening of the muscle. Again, something that can be derived from a Dexa scan report. A value of more than 10 of buckling ratio tells me that this particular patient has a high risk of fracture. And again, this is how a buckling ratio report looks like. In the same patient that I showed the TPS for at the hip structure analysis, you see the buckling ratio at narrow neck is 14. So even though this patient does not have very severe osteoporosis by BMD, has poor bone quality, has a bad buckling ratio. And as you see in this particular study as well, where people with fractures had higher buckling ratio. So friends, I think with this, I would try and conclude and be happy to take any questions. The key takeaways from what we've really discussed today in terms of DEXA scan reports are how it is important for any of us as physicians, no matter we manage diabetes, obesity, muscle mass related issues, how the DEXA can provide a lot of reports and a lot of information in terms of bone density, in terms of body composition, in terms of the newer parameters that have recently been developed. We looked at several cases of osteosclerotic bone disease when we have a higher BMD. What are the causes that we have to suspect? What are the artifacts that we can get? And how we can sometimes have an index presentation just by diagnosis looking at the BMD report. We also looked at a lot of reports of low bone mass. And again, trying to understand how secondary osteoporosis is important in younger individuals, be it alcoholism, be it primary hyperparathyroidism, be it steroid use in patients. And that is also helpful to be diagnosed with the help of DEXA scan. Obviously, the garden variety osteoporosis that we discussed in the first, before starting any of these cases, is something that we all have to be aware of, given that we are managing a lot of patients with diabetes and obesity in our practice. We also discussed assessment of body composition report, talking about total body fat percentage, the muscle mass, the visceral adipose tissue, how it is clinically applied, be it in very lean patients who may have high fat, or in patients who are very severely obese, some who do not develop any complications. Why do others develop all the complications even at lower fat thresholds? Again, the role of visceral adipose tissue through these body composition analysis reports is something we can know. We also discussed about the more recent parameters that are emerging from DEXA scan report, how the trabecular bone score tells us about bone microarchitecture and the hip geometry. I would like to re-emphasize that in patients with diabetes, trabecular bone score is recommended as the most important and most reliable way of assessing bone health. Friends, with this, I would stop here, but would be happy to take any questions.
Thank you, Dr. Nitin. And that was awesome. Okay, so we do have a lot of questions. Before we go to the questions, I would like everyone to know that we have 1,200 people logged in right now, listening to us from across the world. So, Dr. Nitin, is that encouraging to know that that many people are interested to know about the DEXA scan and bone mineral health? I think that's something very interesting for a
Glad to
professor,
hear.
you know. Yes. So over to you. I
Thank
will
you, Nitin.
read
I
out
think it was a
questions.
wonderful session. So many takeaways for all clinicians, and I think you've opened up the whole discussion. I can see on the chat. I'm going to let Archana
I'll
take
be
over
taking the questions.
for all of it, but I think it was a real masterclass. I think this has been a great session. So I'm not going to waste more time, but Archana, take over, please.
Right. So two very basic OPD questions are there, and they have asked very specifically that how do you start drugs in a general OPD for osteoporosis in a person with diabetes?
Right.
So
So
these are two
I
there are
think
two
that's a big
questions,
question.
one in when no resources are limited and one in resource limited setting. So there are two questions from different doctors.
Right. So I think that particular question would require another entire session about management of osteoporosis in people with diabetes. But yes, what we know from literature is that management is no different in people with diabetes and without diabetes. When you talk of efficacy of anti-osteoporotic drugs, that is also similar in patients with diabetes and without diabetes. The short message that I'll give you is that these drugs are extremely effective. Most of the anti-osteoporotic agents reduce the fracture risk reduction by up to 50 to 80%. I already told you about the mortality related to a hip fracture, but if that can be reduced by 80% by very convenient, very less side effects, very cheap drugs, I think we have to prescribe more of those. And in a resource limited setting where you do not have a DEXA scan, there are a lot of screening tools. The FRAX online screening tool, something that would be helpful. And I'm sure we'll be covering this in our masterclass at IDEC in early part of June. So I recommend you can attend that.
Right. So there are questions from Dr. Nina, Naina, and Dr. Naveen, and they're all talking about DEXA in children, right? So doing DEXA scan in children, asking that whether it is safe, how does size adjustment in children happen, and clinical use in children and adolescents.
Right. Very, very important question. So first talking about safety. So I must mention that the radiation that is associated with DEXA scan is 1/100th of a chest X-ray. So it is close to the background radiation that all of us are exposed to. So much so that some recent guidelines also say that pregnant women are safe to be exposed to DEXA scan. So it is very, very important to try and understand that the safety of DEXA scan is not a concern at all. I'll repeat that the radiation exposure is 1/100th of a chest X-ray. So be it a child, be it an adult, no matter how many times you do an DEXA scan, I'm sure all of us or many of us would have had some exposure of an X-ray in our life. So if it is 1/100th of that, I don't think so you need to worry at all. Talking about interpretation of DEXA scan in children, yes, it's a totally different ball game. Which is beyond the scope of discussion in today's lecture. But yes, what we assess in children is the total bone mass. The total bone mass is assessed as the total body mass of the patient without the head. So it is without the head, from neck to the leg, the amount of or the quantum of bone that we have. Again, we do not just look at the age in children. It is very important to look at the pubertal age of the children, because puberty changes the bone strength a lot. We know the sex steroids are very important for bone strength. So I may have two 14-year-olds, somebody who's almost completing puberty, whereas somebody who's in the middle stage. That is important to compare. So there are a lot of caveats that we need to understand. I think in my clinical practice, people with osteogenesis imperfecta is something that I really need to look at bone mass in children. Very helpful for diagnosis, very helpful for monitoring. The other important indication would be juvenile idiopathic osteoporosis. Again, something that is very commonly being picked up nowadays, JIO, and that's again something that we need to look at, but it is the total bone mass that we look at.
So on that note, would you also recommend that this be done for children with type 1 diabetes, young adolescents with type 1 diabetes?
Yes, and there is a study from our center, another big study from All India Institute of Medical Sciences, New Delhi as well. We have enough and more literature that patients with type 1 diabetes have poor bone strength, higher risk of fragility fracture, more than that of type 2 diabetes. And from our simple knowledge in physiology, we know that insulin is an anabolic hormone. So the moment there is insulin deficiency, there is catabolism and catabolism of bone as well. So yes, in children with type 1 diabetes who've got at least a duration of more than 10 years, have completed puberty, have replete calcium and vitamin D, yeah, you can assess the bone strength. There's no guideline as such how frequently you have to do it. But if my patient with type 1 has had a fragility fracture, what I mean by a fragility fracture is a fracture from a standing height, I must assess the bone density because I have very effective ways to treat it.
Right. Thank you. And I think that you have also very effectively answered one question that has come from a couple of doctors here, is that CDC mentions the possibility of future cancer due to DXA. So this has been mentioned, and I think you very well mentioned how it is much, much less than even the X-ray, and it is absolutely safe. So we have a question here saying that do all DEXA scans give body mass indices, or do we have to ask for them?
So you have to ask for it. So basic machine would give you bone mineral density. It depends on the person who's got the machine. So it's just the additional of a software. You don't need another machine or another machine part that you need to get to try and assess. So it's just a software that you need to get added on. Like if you buy a laptop, you need to download maybe a particular app or a software to run a particular system. Very similar to that. It's just a software that you need to buy. It's not the same machine does the job.
So there's one question here asking who should not undergo a DEXA scan. Any contraindications?
Okay, so I did mention a few of the false positives. And if you remember that slide, so somebody who's got a metallic implant, you're not going to get good information by assessing the DEXA scan of that side. It will be all metal. So you'll get a plus 100 for that particular patient. Somebody who's got a CT scan done recently with IV contrast, that IV contrast itself is a false positive. Somebody who's got distorted bone, again, interpretation of DEXA would be difficult. Somebody who's got multiple fractures which have a lot of callus, again, you have to try and interpret in a site where there is no fracture. And like I mentioned, the utility of a lateral DEXA scan, somebody with a hip fracture, you have to make sure that you don't do it in the side of the fracture, but you do it on the other side of it, where there's no fracture. So I think all these are caveats, but by and large, almost everyone can have a DEXA scan apart from these few contraindications.
So somebody has just asked that, are the CVD patients eligible for the scan?
Absolutely, yes.
Absolutely, yes. So there's a very interesting note here. Traditionally, DEXA and FRAC scores were designed for postmenopausal women. Do you think the same cutoffs for the DEXA scan is beneficial and informative for men also, especially older men, where BMD decreases with age and low testosterone levels? It might overestimate osteoporosis in men. So what is your opinion?
Fantastic question. And yes, and that's why I showed very clearly when you need to look at the T-score and when you need to look at the Z-score. So when you look at elderly people with low testosterone, usually more than 75, we define for the disease ADEM, androgen deficiency of elderly male. And there you're going to look at the Z-score and not the T-score. You're going to compare that patient's BMD with an age-matched, ethnicity-matched, gender-matched person. So when you're looking at Z-score, you're comparing to the same age, same gender, same ethnicity. So then you're going to get rid of this bias, which you're talking about postmenopausal women. So less than 50, more than 75, look at the Z-score and you would get the answer that you're looking for.
Right. So we have a question from Mahima asking that a patient taking corticosteroids, should they all be subjected to a scan? And if yes, then how often?
Right. So it depends on the dose and the duration of steroids. So anybody who's been on steroids for, say, a couple of weeks, maybe 6 to 8 weeks, starts to develop problems related to steroids, which are long-term, be it metabolic problems like diabetes, be it the HPA axis suppression, or be it bone health. So I would say that I would look at the whole picture. And if I have a postmenopausal lady who's 55, ideally I would wait for 10 years after menopause. But if the patient has been on steroids for more than 6 weeks, I would still go ahead doing a scan in that patient. But if it is a 30-year-old, I might just wait and make sure that the calcium, vitamin D is replete, maybe do a scan at a later age if the patient is still on steroids. So I wouldn't say there's a hard and fast rule, but you look at the bigger picture of the patient, try and understand what are the risk factors that the patient has, and make a clinical decision whether this patient would benefit or not.
Right. So Vijay here had asked that how often should a DEXA scan be done for patient having family history of osteoporosis?
Fantastic
The basis
question.
of
Very,
that.
very important. Osteoporosis runs in families. Even the JIO that I mentioned, the juvenile idiopathic osteoporosis runs in families. So yes, if you have family history of rigidity fracture, family history of osteoporosis, you should do the DEXA scan in those patients. Rather, we just completed a study where we're looking at siblings with osteoporosis, especially in men. And even we've done DEXA scan in men around the age of 40 years. They have also been found to have osteoporosis. Very recently, we've also published data on premenopausal women and looking at their bone health and osteoporosis. Family history does come up as a very strong risk factor for osteoporosis in them. So yes, if you have family history of osteoporosis, you don't wait for 10 years after menopause. Maybe even at the age of 40, you should be able to screen them, because till the age of 40 or late 30s, you're still accruing your peak bone mass. After that, there is just drop of bone mass. So you should be able to screen them.
Right. So this is a very interesting question from Africa. I'm not sure I'm pronouncing the name right, but it is Orebaule. He's asking, hello from Africa. Using DXA technology requires the bone density measurement, the assessment, composition analysis, along with attention to quality in acquisition. So how do you maintain this quality in India? What is done to maintain the standards in India?
Very, very important. So even though we've imported and we've got a hologic DEXA scan world over, it's imported from the United States, but the quality control lies within the lab where it's being done. So every day morning, there is a QC control. So what this machine comes with is something called as a phantom. It's just like a square artificial DEXA a spine. And we have to run this quality control every day morning before starting the machine for clinical use. And that tells us whether the machine is able to give the right densities as it is there in this validated phantom, which comes with the machine. And so there is a very important quality control step that is done in all these good labs where you ask for DEXA. There's a way to find out the CV of your lab, which is a little complicated to explain in 5 minutes, but yes, I think you've asked a very relevant question. Quality control is very important, and therefore doing a DEXA scan from a proper lab is important.
Right. So very quickly, last 3 questions, and one is from Dilip asking, with corticosteroids and degenerative changes tend to make the bones denser. So is a DEXA that underestimates the risk of fracture? So is that true? And what does one do?
Well, if my patient has already had a fracture, you're right, the callus would tell us falsely high BMD. But again, trabecular bone score is something which is very helpful in these patients. I would often look at the osteoporosis or the spores in this patient in a site where there's no fracture. So if the spine is fractured, I would look at the hip. I look at the forearm.
Right. And although you have talked about it, but a question here says that why is DEXA recommended in cancer, in a malignancy, when it can't show a tumor?
Oh, so it's not done to look at the tumor, but you must know that chemotherapy is something which is detrimental to the bone, and especially most of the chemotherapies also hit the gonads a lot. So both it can cause premature ovarian failure as well as testicular failure, and we know the sex hormones are very important for bone strength. So most patients with cancer are likely to develop osteoporosis much faster than people without cancer, mainly because of the treatment, but also sometimes the cancer can metastasize to the bone as well and can cause fractures because of the metastasis. So again, a way to improve bone strength would be using anti-osteoporotic agents. A drug like zolintronate, which I would usually give once a year. In cancer patients, I give it once in 3 months as well to improve the bone strength.
So I think we will end with a very basic question that has been asked, and that is, what is the technology used for a DEXA?
So, well, the answer is within the name of the machine, which is dual energy X-ray absorptiometry. So that's a full form of DEXA. And we are looking at two particular energies that offer same X-ray. So the X-ray has a higher energy X-ray and a lower energy X-ray. And we see how fast it can penetrate. The difference in penetration between a high energy X-ray ray and a low energy X-ray ray would tell us how strong is the bone, how much is the fat, how much is the visceral fat. So it's basically simple X-ray related technology. For learning more, there are two types. There's a pencil beam and a fan beam type of a Dexa, and we could take another class for that.
Okay, I was going to end this, but we have a question or a comment from a very renowned researcher in India, and Dr. Yagnik sir has sent a note saying that he wants 3 points to be addressed. One is skin fold measurements versus DEXA, MRI, CT. So they have a paper, PLOS 2013. So he's recommended that that be seen. Question he has asked is, do we need Indian estimates for visceral fat, given the differences in phenotype from Westerners, which this machine estimates? And to that, I will add the last question, is any role for height in interpreting adiposity risk? And this will be our last question.
Thank you, sir, for joining in, and thank you for your insightful comments. Yes, your 2013+1 paper is indeed very helpful. Tells us how we can use simpler measures. Based on your paper, I had an objective in my own PhD where I looked at how we can look at METS-VF, which is an algorithmic based assessment of visceral adipose tissue, and compare it with DEXA. Very similar to the fact we when we measure or estimate GFR in patients with diabetes, we don't measure it. We just use a formula to estimate it. So similarly, for visceral adipose tissue, we can estimate the VAT, and yes, simple anthropometric measures, which are more economical and easily available, should be used, sir. So that's your first point. Definitely, we need Indian cutoffs and estimates for visceral adipose tissue, which is something that we are trying to do with the cohort that we have in Kerala. We just finished a 10-year follow-up with that data, and we are trying to see how this can be done. But definitely our machine is tuned from the West. We need to tune it for our side as well. And interpretation of height is very important. And so that's why we have this fat by height square and lean by height square, which needs to be taken into account as well. So thank you, sir, for your comments and having to join me.
Nitin, a quick question to you that you haven't sort of, how does bioimpedance compare with DEXA? I mean, when you look at the body composition analysis, because most of us tend to use bioimpedance scales, so, with a higher number of sensors. So are they comparative, or do you find that DEXA is more accurate?
Right. So, yes, technically they say DEXA is more accurate. We've published one paper from Vellore where we've compared bioimpedance with DEXA. I think the important note here is that when you do assessment of bioimpedance or body fat with bioimpedance, we need to take care of all the precautions that are required, right? From emptying the bladder to kind of whatever restrictions in smoking, alcohol that have to be advised on the previous day, the kind of food intake, timing of food intake. All of these parameters, if taken into account, it does work very well. For all our community-based studies that we've done, we've used bioimpedance, which is fairly good. But I think body water being the most important confounder. Somebody just drinks a big glass of water and gets on a bioimpedance machine, that itself would change the values significantly. So I think taking into the precautions that are required for bioimpedance, this is important. It is comparable. And given that bioimpedance is cheaper, more readily available, it should be used more often.
Thank you.
Thank you. And I think that was our last question. We have a compliment from the Africa Diabetes Alliance saying that it was a great lecture. Thank you so much. So we are also very excited and happy to have all of you from across the world, from Africa, from other continents, and keep joining us. Visit our website, IDEC website, which has a repository of all the IDEC cafes and great talks that have happened over the years, they are listed by the title, by the name, by the author, by the speaker. So you can search them very easily and they can add to the information that you are seeking. And also keep visiting because it also posts all the upcoming events that are going to be there and these IDEC cafes, as well as our national consortium, which comes up once in a year. I think with this, I would really like to thank Dr. Nitin. You have done a phenomenal job of a very difficult topic. And I think it's really stimulated me at least to learn more. I can't say that I know it now. I can just say that I'm stimulated to learn more. Dr. Sanjay Agarwal, we will close with your closing comments.
I think, Nitin, this was superb, but I think this is just a teaser to what we are going to have at the main IDEC meeting, which is from 5th to 7th July in Pune. And I'm sure you'll be running an entire day of, body composition and DEXA and bone metabolism. So I'm sure delegates will be attending the meeting, the annual meeting of the IDEC in Pune. We'll be privileged to hear you and we'll have a great time. So thank you. Wonderful lecture. Very informative, simple, and I think a lot of takeaway message. Thank you very much for all your inputs. Thanks.
Thank you so
Thank
much,
you.
sir.
Good
And
night,
thank you all the
everyone.
delegates from all over for joining in this wonderful session.
Thank you
Thank
and
you.
good night.
Good night. Are we off the air?